So without further ado, I would like to call up to the podium Dr. Bart Scott, an associate member of Fred Hutchinson Cancer Research Center, to talk about dose intensity in MDS and AML. Does it matter? Bart?
Thank you. It's a pleasure to be here so early in the morning. Hopefully people were able to get coffee. The line wasn't too long. So the title of my talk, Dose Intensity in MDS and AML Does It Matter?, requires some background information. And that is, what is dose intensity? And allogeneic transplantation works primarily in two ways. One way is by allowing the delivery of high doses of chemotherapy, which hopefully would kill any malignant cells. But another way is through the graft versus tumor effect of the allogeneic cells themselves. And there have been several studies looking at low-intensity regimens, which were developed for patients of an older age group and also for patients of higher comorbidity scores to allow them to receive the potential life-saving therapy of an allogeneic transplant. There have been several papers looking at how do we define conditioning intensity. And one of those was published by Dr. Bacigalupo, comparing non-myeloablative intensity to reduced intensity conditioning and myeloablative conditioning. With myeloablative conditioning, there tends to be a longer duration of cytopenias that are irreversible without infusion of allogeneic cells. With non-myeloablative conditioning, the duration of pancytopenia tends to be shorter, and patients can have recovery of stem cell function without the infusion of allogeneic cells. And reduced intensity conditioning regimens are somewhere in between these two extremes. Dr. Girault led a panel of approximately 56 experts in the field of allogeneic transplantation trying to define what is considered to be reduced intensity conditioning regimens. And this is from the CIBMTR operational criteria. And these were the reduced intensity conditioning regimens that people agreed on, and this is the percent in the top two. Admittedly, it is a controversial area in what's considered to be reduced intensity conditioning in myeloablative versus non-myeloablative, and I think probably a better way than drawing lines between them is to think of them as a continuum. Retrospective studies have shown that patients with MDS on the left here and AML on the right, have similar overall survival, but have different causes of death. So this study was primarily done in MDS patients who had less than 5% blast at time of transplant. The standard conditioning regimen usually consisted of TBI at higher doses greater than 8 gray, or busulfan at busulfan at 16 milligrams per kilogram. And these are the reduced intensity conditioning regimens listed here. And you can see that the overall survival was similar between the standard or high dose conditioning regimen and the reduced intensity conditioning regimen, but the cause of death was different. And the patients who received a reduced intensity conditioning regimen were more likely to die of relapse, whereas the patients who received a high-dose intensity conditioning regimen were more likely to die from treatment-related mortality or non-relapse mortality. Now, this, of course, is a retrospective analysis, and there's a lot of decision-making that goes into selecting who receives a high-dose intensity regimen and who receives a low-dose intensity regimen. With the AML patients, you found a similar finding, that there was no significant difference in overall survival at 2 years, but the patients who received a reduced intensity conditioning regimen in red here are more likely to have relapse, whereas the patients who received a high intensity regimen were more likely to have treatment-related mortality. So all of the retrospective studies seem to indicate that there was a similar overall survival, but a different cause of death. Now, this raised the question of what about the disease status at time of transplant was that important? And smaller studies have shown that if patients are in remission at time of transplant, there did not appear to be a benefit in increasing the conditioning intensity. So this is a small number of patients, as you can see on the slide. The FB2 is 2-day busulfan, which is about 8 milligrams per kilogram of oral busulfan. And the BuSci in FB4 is 4 days of busulfan, which is about 16 milligrams per kilogram of oral busulfan, or its IV equivalent. And what they found is that if you're in remission at the time of transplant, there was no difference in survival between a 2-day busulfan regimen versus a 4-day busulfan regimen. And this was done in MDS and AML patients. But if you had active disease at time of transplant, there was a big survival benefit with 4-day busulfan regimens in comparison to 2-day busulfan regimens. Again, this was a retrospective comparison, and it was looking at disease status at time of transplant. This is one of our internal studies that we did comparing conditioning intensity for patients with MDS, and we found that if MDS patients had less than 5% blast at time of transplant, there was no difference in the rates of progression. So again, indicating that disease status at time of transplant may be informative. So on the basis of this, the BMT CTN designed a trial 0901 to prospectively, in a randomized fashion, evaluate conditioning intensity for patients with MDS or AML who were in remission with less than 5% blast at time of transplant. Because patients would be randomized potentially to a high-dose intensity regimen, we limited the age to 65, the comorbidity index to less than 4. We wanted matched donors, so it included matched sibling donors or matched unrelated donors as defined by the NMDP. That means a 7 out of 8 match. We used bone marrow or peripheral blood as stem cell sources. Patients had to have no CNS disease at the time of transplant. They could have had a history of CNS disease, but no CNS disease at time of transplant, and no circulating peripheral blood blast were allowed. After screening, patients were randomized to receive either a reduced intensity conditioning regimen or a high-dose intensity conditioning regimen. There's another slide that defines what these intensities are. The GVHD prophylaxis was per institutional guidelines. They were all T-replete grafts, and post-transplant Cytoxan was excluded. The primary endpoint was 18-month overall survival. So these are the definitions of the reduced intensity conditioning regimens allowed versus the high-dose intensity conditioning regimens. There were several meetings that we had to determine what would go into these. A lot of this was based on surveys from potential centers that would accrue patients, and we needed to come up with a way that we could do this trial in order to complete it. And so we included a 2-day busulfan regimen and the melphalan regimen. And so these were the 2 reduced intensity conditioning regimens. We allowed for 3 high-dose intensity conditioning regimens, and that was 4-day busulfan paired with either fludarabine and Cytoxan or a high-dose TBI-based regimen. There were some investigators who argued that in the younger patients with a history of CNS disease, they would prefer to give a high-dose TBI-based regimen. The primary endpoint was 18-month overall survival. There were several secondary objectives listed here. Our hypothesis was that we'd be able to decrease the treatment-related mortality with the reduced intensity conditioning regimen and thereby improve the overall survival at 18 months. And that was because all of these patients would have less than 5% blast at time of transplant, and the hypothesis was there was no benefit in intensifying their conditioning regimen. The target accrual was 356 patients, 178 to each arm. There was 80% power to detect a 15% difference in overall survival. Interim analysis were built in at 25, 50, and 75% of accrual. It was a 2-sided test to detect the difference in overall survival, and the p-values were adjusted for multiple comparisons. The final accrual was 272 subjects, 135 to the high-dose intensity arm, and 137 to the low-dose intensity arm. The Data and Safety Monitoring Board closed the accrual at the second interim analysis. So this is the Consort Diagram. There were 285 patients who were screened for eligibility. There were 13 patients who had a screen failure, and this was primarily due to disease progression. So at the time of their marrow aspirate, they had greater than 5% blast by morphology and were excluded from the study. There were 272 patients who were randomized. It was an intent to treat analysis. The vast majority of patients received the assigned treatment. Of the 135 patients who were randomized to the high-dose intensity arm, 131 received a high-dose intensity-based allograft, but 4 did not, and the reasons are listed here. Some relapsed, that was the primary reason, and then with the reduced intensity condition regimen, 5 did not, and the reasons are listed here. And again, the principal reasons had to do with relapse prior to conditioning, withdrawing consent after randomization, physician decision. So the majority of patients did receive the assigned allograft. These are the characteristics of the patients who were enrolled. The median age was 54, balanced between gender and primary diagnosis. The vast majority of patients who were enrolled into this trial had AML, not MDS. 80% of the patients had AML. Only 20% of the patients enrolled into this study had a diagnosis of MDS. I say this because I can only present the data we have, and so sometimes people try to extrapolate beyond the data that they have, and I think we have to be careful with that when we're evaluating these trials. The disease duration in both arms was 6 months. This is the WHO classification of both the MDS and AML patients, and you can see that it was balanced between both arms. We did look at other factors like mutational abnormalities, CR1 versus CR2. We also looked at IPSS risk score. We also looked at cytogenetic risk as defined by SPLOG and as defined by IPSS. I don't have room to put all of that up here, but I can tell you it was equally balanced between both arms. There was only one stratification in the study, and that was transplant center. So these are the conditioning regimens. The vast majority of patients who received a high-dose intensity conditioning regimen received a 4-day busulfan regimen. 94% of the patients who were randomized to high-dose intensity conditioning received 4-day busulfan. And then when you look at the reduced intensity conditioning regimen, 80% of the patients received a 2-day busulfan regimen. Only 20% received a melphalan-based regimen. These are the GVHD prophylaxis that was in the study. The vast majority of patients received a TAC methotrexate-based GVHD prophylaxis regimen. We did allow for the use of ATG, but the use of ATG had to be declared before randomization so that ATG was used whether you got a high-dose intensity conditioning regimen or a low-dose intensity conditioning regimen. Donor type related versus unrelated. Again, it was a 7 out of 8 defined NMDP criteria, so there were some mismatched related and unrelated donors. The vast majority of patients had peripheral blood as their stem cell source. So the overall survival was not significantly different between two arms. We did an 18-month point-wise comparison of overall survival. So we didn't do a continuous hazard comparison. And the reason why is because it was felt at the time that the study was being designed that the proportional hazards ratio may not hold up over time. And proportional hazards has a requirement that there would be a similarity over time in regards to death and the cause of death. And we knew that with the high-dose intensity regimen, or we thought, I should say, with the high-dose intensity regimen, there would likely be earlier mortality, and with the reduced intensity regimen, we thought there would likely be later mortality. The earlier mortality with the high-dose intensity regimen we thought would be due to the treatment-related mortality, and the later mortality with the reduced intensity regimen we thought would be due to relapse. So the primary endpoint was an 18-month point-wise comparison, and it was 9.7% between the two arms, and this did not reach statistical difference, but it was close at 0.07. When you look at the difference in survival between the two disease groups, there was no significant difference at all for MDS between the reduced intensity conditioning regimen and high-dose intensity conditioning regimen. Again, there were a low number of patients in the MDS group, only 27 in each arm. For AML, there was a significant difference in overall survival with a p-value of 0.027, and again, this is the 18-month point-wise comparison. Why? Well, it was primarily due to relapse. And so when you look at the relapse-free survival by treatment arm, the high-dose intensity conditioning regimen had a much better relapse-free survival in comparison to the reduced intensity conditioning regimen. And this is what led the independent Data and Safety Monitoring Board to stop accrual to this trial. It was significantly different at 18 months with a p-value of less than 0.01. The difference was 20.4%. When we look at disease type It didn't matter which disease type you had. There was still a significant difference in relapse between MDS patients, reduced intensity, high dose, and AML patients, reduced intensity and high dose. There's a 50% 18-month incidence of relapse for patients with AML who got a low-intensity preparative regimen. So I showed that the survival was not different for MDS, but it was different for AML, even though the MDS patients also had a much higher rate of relapse. Remember that we looked at survival at 18 months. Now, I can't say for certain what's going to happen with longer follow-up. Will the relapse patients who had MDS convert to mortality? One may suspect that this will be true, but we'll need to follow these patients for a longer period of time to see if the higher rate of relapse in MDS converts to mortality. When you looked at treatment-related mortality, there was a significant difference. The treatment-related mortality at 18 months was 15.8% in the high-dose arm and 4.4% in the low-dose arm. Causes of death, the principal cause of death was relapse for high-dose intensity conditioning regimen. I'm sorry, for low-dose intensity conditioning regimen and GVHD for high-dose intensity conditioning regimen. I'm going to skip some of these slides. There was a significant difference in GVHD, both acute, grades 2 to 4 and 3 to 4 for high-dose intensity conditioning, a higher incidence of that. And chronic GVHD was higher in the high-dose intensity conditioning arm. These are the multivariate analysis. We adjusted for several factors listed here, but once we did that, you can see that there was a significant difference in overall survival with a benefit to the high-dose intensity conditioning arm. Subgroup analysis showed that patients with low comorbidity, patients with high-risk disease, and older age patients, and patients with AML all benefited from high-dose intensity conditioning. It's not the only study that's looked at this, and so in fairness, I just wanted to publish the results by Dr. Bornhause in Lancet Oncology in 2012, which showed no difference in treatment-related mortality, relapse, or overall survival. This study was stopped early due to poor accrual. So in summary, the incidence of acute and chronic GVHD was higher following high-dose intensity conditioning regimens. There was no significant difference in overall survival. The reduced intensity conditioning regimen result in significant increased risk of relapse and an inferior relapse-free survival. High-dose intensity conditioning regimen remains the treatment of choice over reduced intensity conditioning regimen if the patient is an appropriate candidate for high-dose intensity conditioning regimens. And novel, less toxic myeloablative or effective post-transplant maintenance regimens are needed to improve disease control in those who require reduced intensity conditioning regimens. Thank you.